Great. Well, in the interest of time, we shall get started. I'd like to thank everyone for joining us. This is the an entry in the ongoing webinar series that we've done focused on the intersections of the war on drugs, social and structural inequity, and mapping out how we might understand where we can go and respond as we move forward to undo the harms of the drug war. The webinar series itself is co-sponsored by the Yale Program in Addiction Medicine, the UCLA Center for Social Medicine, the School for Advanced Studies in the Social Sciences, the National Survivors Union, and the Drug Policy Alliance. This will be the first in a series of webinars that we'll be running for the next three, focusing on the shift to synthetics in the drug supply, where really we're taking up a different question in each of these webinars structured around understanding and characterizing what's happening, why this shift has happened in the drug supply more broadly, how we can best intervene to respond, and effectively where we can go as we're experiencing these large-scale shocks to the drug supply, which are threatening to go global, given some of the signaling certainly that we're seeing in Europe and elsewhere. And so within that, how can we collectively learn from the experience, what's gone right, and more so what's gone wrong in North America amidst this shift? And how can we intervene to keep people alive as we deal with a rapidly changing supply being mapped on to ever greater social structural inequities? I'm pleased to have with us, you really couldn't ask for a better panel. I will let folks briefly introduce themselves. After I briefly mention, we have Jaime Arredondo from the University of Victoria, who's been instrumental in helping us understand what's happening with the drug supply. Uh, Maritza Perez Medina from the Drug Policy Alliance, who's a critical force in working to undo these harms and helping us especially understand the legal context and regulation more broadly within the supply. And Louise Vincent, whom I'm sure I probably don't have to introduce for anybody who's joining, a leader with the National Survivors Union, who's been instrumental in positioning us to best respond and calling for more meaningful responses amidst the overdose crisis, the center people who use drugs, their knowledge and expertise as what we really need to be building off of. Before we jump into questions, I will let people kind of more broadly introduce themselves. And I will mention, and this is in the chat, that closed captioning is available and translation. So please do enable using the directions that are in the chat if helpful. So I guess first, more broadly, I'm going to ask people to just speak a little bit more about the work that they do and their positioning within it. Um, and if you don't mind, if we could start with Maritza.
Yeah, thank you so much. I'm so happy to be here today to talk about synthetic drugs. My name is Maritza Perez Medina. I'm the Director of Federal Affairs for the Drug Policy Alliance. I think many of you are familiar with DPA, but in case you're not, we're a nonprofit that works to end the war on drugs. We work at a national level. I have the privilege of running the federal office, which, has some of its challenges, and I'll talk about that today. But essentially what my job is talking to Congress, lawmakers, and talking to the administration about all things drugs, all of our policy priorities. Right now, that looks like marijuana reform. It definitely looks like stopping the criminalization of fentanyl and xylazine, addressing collateral consequences. It looks like criminal justice reform. Yeah, that's I think a good background, and you'll learn more as we go. Thank you.
Great, thank you. Now, Louise, would you mind introducing yourself a little bit more and talking about the amazing
Sure.
work you're doing?
So, most of you know, I work with the National Survivors Union, was Urban Survivors Union, and I work with North Carolina Survivors Union. So all of these are drug user unions, basically affiliate groups of people who use drugs. And what that really means is we are the people who have done the structural analysis, who have done the work, who really understand what's happening on the ground, and are looking at it, and experiencing it in real time. And it's so important that we are listened to and heard. I mean, we could have talked about xylazine years ago, and we were talking about xylazine years ago. Um, we've been talking about this stuff. Um, our our ability is unique right now. We have never had such a such a unique opportunity to present and to be heard in a public health framework, and and just in general. They used to talk about drug users as a hard to reach population, and now we are not hard to reach. We're here today talking. There's no reason not to be talking to us, and I feel so privileged to be here. So thank you, Ryan, for uh, creating this space, because I think this is exactly how we get to a place where we go beyond research into practice and really start saving the lives of all of these people who are dying.
Great. Thank you, Louise. And I will cycle back about so many of those because I have so many questions for you. Jaime, chat about yourself and the work.
Yeah, thank you, everybody. First, I would like to acknowledge that I'm joining you from unceded territory, from the Sankis, the Esquimalt, and Wasanic people whose historical relationships continue up to this day. I'm Jaime Redondo. I'm a Canada researcher on substance use at the University of Victoria, and I collaborate with a couple of harm reduction organizations in the U.S.-Mexican border, Prevent Casa in the city of Tijuana, Bertet in the city of Mexicali, and On Point in the city of San Diego. And I would like also say that while I consider myself a person who uses substances, I have never been negatively criminalized and affected. And, I would like to put that in perspective from that privilege, that I would like to kind of like bring this perspective of what I have learned about our drug toxicity has always been in tandem with the work that I do with the community organizations. And thank you for having me, and looking forward to this talk.
Great. Thank you. So as we jump into conversation, certainly folks joining us will be aware at the beginning, nearly a decade ago, we've seen a shift in the drug supply as synthetic opioids like fentanyl, other analogs have largely replaced heroin and prescription opioids in the US and Canada. More recently, since the outset of COVID-19, and again, as we've seen this broader transformation in recent years, we've also seen an increase in synthetics in Mexico and Europe, and certainly in other places where these are popping up sporadically first and then often replacing supply. And so maybe to start us out, Jaime, may put you on the spot right away. Before putting to the panel, what dynamics do you feel are contributing to the shift in the drug supply where you work and more broadly? And in your case, the places where you work, because your work is multi-sited.
Yeah, thank you, Ryan. I think I was just reflecting that, having that privilege of being able to work in 3 countries, both in Canada and the US, but also seeing it from the lens of what we saw in Mexico. And it puts you into perspective, kind of like hindsight is 2020, right? Like, for example, how we started seeing our changes in 2017, 2018 in Mexico, and then start thinking how that was mimicking to what's happening in the United States. And I could just go really directly, it's criminalization, right? It's when we started making it more difficult for heroin production to arrive to places like Vancouver or in the United States. Organized crime sees an opportunity to introduce a different substance. And then the markets, let's not forget, they're all interconnected. And the people in Mexico who are in charge of production see an opportunity to adapt to that new demand that is created by those northern countries. And then that modifies the things that we start seeing in our country. And we evolve into this spiral of, okay, then if it's not now fentanyl, let's mix it up with something new. We start seeing now psilocybin as well into our region at the border in Mexico, something that you started seeing many years ago in Puerto Rico and east of the United States, and now showing up also in Canada, or we start seeing benzodiazepines in Canada mixed already with a local supply. So how long until that one trickle down to other parts? So ultimately, I believe it's really the criminalization of the world of drugs that is leading us to find new products to just, substitute those that are becoming more difficult to find and produce.
Thank you. And building off that question, Maritza, I'm wondering how else you could expand out our thinking around that, and specifically thinking about America as an actor in this space that produces many of these dynamics that are driving drug-related shifts.
Yeah, thanks. I'll just add a little bit more color to what you were saying at the beginning of your remarks, Ryan. So just so folks know, that this is really the fourth wave of the opioid overdose crisis that we're seeing in the US. And it started with prescription drugs, but after there was a crackdown on those, people turned to heroin, the street supply of heroin. A crackdown on that then eventually led to fentanyl, and now we have fentanyl analogs, and as you're going to learn on this panel, other substances in the illicit drug supply. And it's exactly what Jaime said. It's, the iron law of prohibition, that this idea when you crack down on one substance, something will come into the market to replace it. And we've certainly seen that. I think another dynamic that we should talk about, though, is certainly the pandemic. I know the pandemic brought a lot of pain to a lot of individuals and a lot of families, and we did start to see overdose rates also increase during COVID. And if you think about it, it sort of was a perfect recipe in terms of what leads people to using drugs in a harmful way. We saw that people were in isolation, and of course, that put people more at risk of using drugs problematically, especially when you're talking about just the trauma of the pandemic and a lot of stress, including financial and mental stress that people experienced during that time. So both of those things, were definitely contributors to what we saw in the US. I think on the flip side of that, like one positive thing that I did see during the pandemic is that I saw more conversations about treating drug use as a health issue. That was something that I really started to hear, certainly with the Biden administration and definitely coming from Congress. And I think it had to do definitely with the times, the fact that we were like facing a double health crisis, right? It was the pandemic plus overdose. So, I mean, I don't want to say there was anything positive, but I guess maybe a silver lining that came from that.
Great, thank you. And Louise, I think really grounding this in what community experience has been especially, and in relation to the broader advocacy and efforts you're engaged in, kind of how would you characterize kind of what's been driving the shift and what you've seen as this has emerged?
Well, I mean, I think early on it was the removal of the pills, right? It was the nobody's gonna make the jump from from medical to street, and we did. Every people did start using street drugs. And that was the initial, but COVID um came in where, with that, it was already a disaster, right? We were already seeing just overdose deaths that were outrageous. I mean, communities were already devastated before COVID ever came. So we need to be very clear about that, that it wasn't COVID that drove it. It was it was the politicization and certainly criminalization, but the politicization of medical systems, having people regulate medical decisions in the that's not where we need to make medical decisions. People are, very different problems, and you cannot regulate how many pain pills a person can have based on this or that or the other. And criminalization absolutely being in the middle of that, which affects every bit of privilege. The people with the most privilege, having more access, and then the people with the very least privilege having zero access, and really being pushed to this unregulated supply. And then the day COVID hit, I mean, the day the world shut down. And let me just say, this was a devastating kind of realization for many drug users too. I was sitting on a panel when it happened, and I remember being so angry because I was like, look, the world can stop. They stopped the world for a flu that I don't see right now. They stopped the world, and we can't get them to listen to one thing we are saying about the hundreds of thousands of people that have died of overdose death, and the people in prison, and I mean, it was just that's when we knew that we had been, hoodwinked. This was, I mean, they can stop the world. They can make these changes, and they did not. So throughout the entire pandemic, there was silence. Like, it was very quiet among many of the groups. And we did see, the talk of public health response here and there. We used to hear we're not going to arrest our way out of this, but I don't hear it anymore. I certainly don't hear it anymore. I hear a doubling down of the drug war. I see devastating effects of the drug supply. And it is not like regular supply and demand. It is whatever you put out there to substitute, people will pick up. And you see it in prisons, whether it's Suboxone or whether it's some form of whatever drug is available, whatever is available, people will use. And we are now seeing another devastating piece that I don't hear a lot about, and that's where's the Adderall, and these prescriptions for stimulants that people are not able to fill at the pharmacy. And if they don't think those will be filled on the street, they will as well. And so we will see the devastating effects of that. And we know all of the stigma around crystal methamphetamine as well. So as those pieces of criminalization start to come out, and we start to hear about that, I mean, these things have consequences, and they don't make sense to those of us on the ground that are trying to understand what's going on. I think it's very important that we get the knowledge from the spaces and places that have the knowledge, and we get them to the street so people understand what's happening. But I'm afraid people don't believe what's happening anyway. I know I struggle to believe a lot of what comes out, because it doesn't make sense. You can do this, but you can't do that. You can do these things, but you can't do those things. People are dying, and I see an awful lot of people patting their backs and feeling like they're doing good work, and it's not making it to the streets that I'm on. And I need to say this: there is also a picture of disorganized crime that we need to talk about in rural areas, and in areas where there is, organized crime at least keeps things organized, right? I'm not saying it's great, but it's better than disorganized crime where anybody can be a drug seller, anybody is a drug seller, and we've got really increased rates of criminalization. And so we have disorganization. People don't know what they're doing. People are putting just anything out on the street. So I never hear that term, this idea of disorganized crime. But we need to start talking about that too, because in the places that are already hit the hardest, the rural areas, the poor areas, that's where we're going to see a lot of really, at least organization, and organizations don't want to kill their customers, right? And nobody wants that, but it's what happens when people don't know what they're doing.
Yeah, no, thank you. Louise, you brought up a lot that I want to cycle back to, particularly toward the end, this point of COVID showing the transformations that are possible when we actually give a damn whether or not people die, at least in theory, especially in those early days, and what that means for how we think about the overdose response. I'd like to pause and cycle back a little bit to introductions because we have a panelist joining us we thought we had lost due to my ever confusion with time changes and differences. Marika Ferry from the European Monitoring Center for Drugs and Drug Addiction. Wonderful, and you're here. Would you mind
Hello.
taking a moment to first, thank you for joining us. Would you mind taking a moment to introduce yourself and the work? And then I'll have a kind of a question related back to what we've been discussing that I'd like to put to you.
Thank you very much. So my name is Marika Ferri. I'm based in the European Union Agency for Drugs, the European Monitoring Center for Drugs and Drug Addiction. As a background, I'm an epidemiologist with a specialization in systematic reviewing of evidence, and this is my main role in the agency, dissemination of evidence-based interventions. So thank you for the invitation.
Great, thank you
And
for
sorry
joining.
for misunderstanding the time.
I can never understand. I'm the person who's always missing people in other time zones, so no need to apologize. One thing we've been discussing is forces that are underlying some of the drug-related shifts that we're seeing in the supply right now. And I think certainly Europe's at a very interesting moment right now, where certainly we're seeing kind of sporadically and maybe in a more organized way increases in, for example, nitazines in the supply, or even sporadically fentanyl. And I'm wondering if you could talk a little bit about what you feel or some of the underlying dynamics that are now possibly driving these changes, which we hope turn into a shift like we've seen in North America?
I'm not an expert in the market. I can share, if you allow me, I can share with our audience some publications by my colleagues. We don't have such a severe problem in Europe. And also, I hope we are protected by the national health systems, especially from the overprescription. Then in the European Union, we have the European Drug Strategy, that is a document released in collaboration by the Commission and the countries. And this sets the line to be followed by the countries where there are recommendations around harm reduction interventions. So in all the European countries, there are interventions for harm reduction. And although we have opioid overdoses, we tend to reduce these risks to outreach units, drug consumption rooms, drug checking, try in many countries to provide free services for people who use drugs. So this is what we try to do. In terms of shifts in the market, this is really, unfortunately, not my specialty, and I'm not able to give a detailed view. What we are observing is an increase in the use of psychostimulants that is of concern, because we are less prepared to treat, for example, these problems. And fentanyl appears in our reports, but not in such a massive problematic way. But yes, as you said, there are new opioids that we take under control. There is a system, an early warning system, so that the European Union tend to try to control and to prepare, especially we have now, sorry, our agency has been extended the mandate, and we will have a line of interventions called preparedness and threat assessment, where we will also foresee collaboration with other regions to try to be as much prepared as possible.
Great, thank you. Building off some things we've been discussing, Jaime and Louise, you've both specifically been involved with community-based drug surveillance, primarily through community-based drug checking efforts, which, I would say have been instrumental in helping us understand what's happening in the supply as it shifts. And have especially been critical as we've seen a shift to synthetics and other things in the supply. And Jaime, you chatted a little bit about this. Maybe I would put to you first is, how would you characterize how the supply has changed over time? And very specifically, I think when we often talk about this, we talk about supply shifts as linear. And I'm wondering if you could characterize kind of the dynamic aspect of the supply that leads it to kind of be more volatile than anything in many cases, as opposed to it often being an outright replacement of one thing with another.
Yeah, it's interesting to think, again, like I was saying, hindsight 2020, right? I mean, when I was doing outreach work in wound clinics, and one of them in Tijuana by Dr. Patti Gonzalez, and we started seeing wounds that resemble crocodile, in the streets of Tijuana. And I remember looking at those wounds, and now I can think, after all these years, how perhaps was some changes that perhaps what Luis was referring to, unorganized crime of people trying to maybe at the local level trying to find a new combination, and then see how that jump, and we start hearing from the community, directly from the community, this is stronger, this is why we need to put attention and start doing and mimicking some of the methods that we started developing in British Columbia, particularly for fentanyl testing strips. And then we start seeing, for example, we didn't notice that, a new powder started coming up, which it was the China white, which it was not traditional in Mexico. Mexico really had been for a long time black tar territory. And then we started testing it, and we started seeing, for example, black tar non-positive for fentanyl, China-wide positive for fentanyl. And then you start thinking, well, okay, so it's going to be just in one thing. Should we recommend clients that if they don't want to, have a higher overdose risk, just stick to one product? But then we started seeing how it started jumping. And something that we thought that it was not easy to do, which is adulterating black tar with fentanyl, started happening. And now we had a market, and just like Luis said, we did some research in our safe consumption service in Mexicali with some of the women who were using the site and doing the drug checking. And they were telling us the same, that if they could, they would not want to use this. They would prefer to use something else. But the market dynamics was that they could not find anything else, right? And then we start hearing more about silencing. And then at times I think, like, are we the same ones who are kind of making it more popular? So unorganized crime start mixing it because, they hear this word. We didn't know anything about fentanyl, and suddenly now it's at least in the legal opiates everywhere. And now we start seeing silencing. But then if we put that into perspective with what we know in the Canadian setting, is that it can also be like waves, right? It not necessarily means that suddenly just everything is going to be tainted with just the same percentage of concentration, but it comes maybe into waves. And this might be either determined by restrictions in the ability of precursors. It might be because a batch that it was at that moment came out heavier than usual. And those are the problems on unregulated markets, that if we don't measure it, and I don't want to say we as researchers or the governments, but if the community organizations that are the ones who have the direct contact with the people who are using substances don't have the ability to measure it, then we cannot really determine what the best actions are for that contaminated supply, right? It could be like, don't use this one. We'll try to get something that might be less contaminated, or any other really direct harm reduction strategies that we need to put into the hands of people who use substances. But we need to recognize that it comes in two waves, that is not static, that is not automatic linear, and then it is also extremely geographically concentrated, right? That what we might see in one part might not be necessarily what we see even from the same state. And that's why we need to have these kind of like decentralized solutions to address these particular unique situations on the community level.
Yeah, Jaime, I appreciate you specifically bringing that up, because especially even the tendency we have to kind of totalize drug supply shifts. It's now fentanyl everywhere. I mean, certainly it is. But that can mean different things, as you mentioned, in terms of other adulterants across the supply, potency as it maps onto geography, which can necessitate very local responses in ways that work, capture the dynamic nature of how drugs move through regions, communities. Louise, I'm wondering if you could characterize and help us understand how you've seen these shifts in the supply evolve over time.
Well, I talk about statistics in real time. We what we get is we get waves. People dying, people coming in. If you have a drop-in center, you need to listen to the folks that are on the street that are, you'll start to see wounds, you'll start to see trends, and people are quiet about those things because most of the time they're negative consequences, not positive consequences. So they don't want to talk about it. A lot of times, when we talk about markets that um, are unorganized, people may think that someone passing out is a good drug. So they see someone use and they fall out. Oh, that must be strong. That must be good. That's not the way it works. So if you don't understand what you're seeing, then you're seeing someone, heavily tranquilized, and you think you've got a good batch because they are affected, right? And so then so you hear lots of stories of lots of people, oh, the naloxone's not working or this or that, which isn't usually the case, but it's taking longer. It's not, maybe, you know things are considerably different. You will know by what people share, and by what people talk about if you have a relationship with the community. If you don't have a relationship with the community, you can you're not going to hear anything. You're going to be, you know, you're going to be avoided at all costs. But if you have these really important relationships with the community, you're going to see this stuff. And if you know the questions to ask, and if you know sort of like how to get at some of these things, you can really get some information. But the problem is you know, things in more rural areas may come from a whole bunch of different places. Somebody may go here and get a little bit, and somebody may go there and get a little bit, and it can all be contaminated. But the biggest thing that I see is people talking about drugs like they're, like we use them solo. Like this is a heroin person here. This is a cocaine person here. This is a da 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 da. Polysubstance use is even more the trend now than ever before. I think it maybe had to do with what was available in younger times, but right now you almost have to use groups of drugs to create the feeling that you're trying to create, that is whatever it is that is helping you, or you enjoy, or for whatever reason you use drugs, right? For whatever reason you're using the substances, you're trying to create, some I don't know, semblance of what it was before, or what helps you feel the way you want to feel. And so that requires polysubstance use, and we just don't have the tools, a lot of times, to deal with polysubstance use, and a lot of times, needle exchanges, things like that, the way we talk about drugs, the rules we have around pipes, the rules we have around like all of these things. I mean, we no longer use the word syringe service program. Sometimes I mess up, but we're trying to use drug user health hub. We're trying to talk about snorting drugs, drinking drugs, spoofing drugs, drugs in your, smoking drugs, injecting drugs, any which way you can get the drugs in you, because the way people use drugs is different now. It used to be you sort of started in a linear fashion. You started maybe eating them, snorting them, smoking them, and then injecting them. And now sometimes people are beginning with injection. And so you have varied, if you're using the same tools you were using before to teach about any kind of substance use, you need to throw that away and you need to start over. We are in a different market. We're using different drugs. We're using a different supply. I don't think I answered the question you asked, but it's all over the place. And I think that if I could get one message across, it would be that it's chaos. It's chaos. And anytime you have chaos, you have a lot of unintended consequences, and people getting harmed, and people are getting harmed, and they're not. I mean, when we talk about the dangers of the drug war and the damages and the costs, we still aren't incorporating the cost of infection. Um, these wounds, we are creating a wound care room in our site that's solely designed so that people can even treat their wounds. I mean, if you don't have a home that has very clean, surfaces, it's hard. These are huge wounds sometimes. How are you going to treat something like that? And let's not talk about the cost of the wound care. I mean, just to get a bandage can be $80. I mean, just a regular bandage with no adhesive. So, like, I'm telling you, we have some costs that need to be looked at by public health. We have different needs than we had before. People are going to need to change up the way they do almost everything if they want to really address and get information, because nobody's going to walk in, slide up their sleeve and say, look at this mess, that I'm already want to, just am devastated over. And now when medical people see it, they're stigmatizing me even further. I can't get any help. I'm actually at risk when I go to the hospital because I have open wounds. I know this just goes on and on and on, but we need to listen. We need to really get in there and find out what's really driving, the crisis right now? What's happening? And I would say it is the xylazines and if you don't have an FTIR somewhere in your city, get one. Find somebody to donate. Write grants. Talk to folks until somebody will listen. We were lucky enough to have Nan Golden. I mean, and I will forever be in her debt. I mean, it has saved so many lives for us to have an FTIR, and we're the drug user health hub with the very least amount of uh, monetary. We have no money, but we do have access to powerful tools that are helping people stay alive, and they're just now learning how to use them. They're just now understanding why it's important, and we're working with drug sellers who do care. They do care, and I have evidence of that, and they're coming to our site, and they are wanting their drugs tested because they don't wanna buy xylazine, they don't wanna put it on the street. They are actively pushing back to the people that are, so there is a pushback. So if we could just get people knowledgeable, and if we could just get the right stuff, we have a pathway forward.
No, thank you, Louise. And I think you've captured a number of things, but certainly is how destabilizing this moment that we've been through is. Where at every moment where we see a shift, be it long term or just one of these abrupt changes that we see in supply, the reality is our systems of support that we have for folks who use drugs are so collapsing at every moment that anytime we destabilize everything else, they inevitably fail and fail
Well,
very trying to
and
serve.
and let me just say, we have conditioned people to be used to buying purple fentanyl or green, this, or, people are used to purchasing things that don't look like what they're supposed to look like. And so we have to have these drug testing or drug checking supplies because people spent years learning how to observe and tell if a drug was good or bad, or, what was in it. And, that's what you learned how as a drug user. You learn how to determine quality and all of those things. And right now there's no way to tell. You are what gets what when it gets checked on, and that's truly dangerous. I was just saying, sorry.
Yeah, no, thank you, Louise. There's a question by one of the attendees, thank you, Nina, that I'd like to put to everybody. And certainly we've seen this in our own work, is how drug supply shifts are intersecting with structural racism to effectively structure out how we respond and the disproportionate impacts that we're seeing, especially in communities of color. I think specifically to my partnered work with Indigenous folks who use drugs, who are really among those most impacted. And we've come to understand that for so many people on the ground who are experiencing tremendous loss on an ongoing basis, that it leads folks to very much position the overdose crisis as a project of settler colonialism pursuant their extermination, with folks terming it ventricide often in order to characterize what it is that they're talking about, or gentrification specifically toward their displacement. I hope you don't mind, Maritza, if I put to you first how you're seeing these intersections of structural racism amidst this broader shift um, to synthetics, and what that specifically means in terms of how we enact the various often legal strategies that get employed in response to, for example, fentanyl or xylazine.
Yeah, I think about the most prominent example that I know of that I see at the federal level, and that's like, members of Congress and even the Drug Enforcement Administration talking about victims of, well, that's their word, right? They would say victims of opioid overdose. But when they say that, they're specifically talking about a specific type of person, usually a minor, usually someone who's white. And there's still this, underlying message that's unsaid, that the people who are selling drugs, the drug traffickers, are Black and brown people. And that's why we're seeing really intense criminal penalties at the federal level for drug use. And one thing that I try to do when I talk to lawmakers' office is try to help them understand that, like, we're not talking about different people when we're talking about drug sellers and drug users, that oftentimes we're actually talking about the same person. But for political reasons, they like to pretend that these are two different groups of people. So that's been really, really incredibly infuriating. I think there's something to be said about, like, definitely more education that needs to be done there. I do think some of that is intentional, where people try to pretend they don't understand that difference. But I also think that, as somebody who goes into these offices, sometimes people are really surprised to hear that. There's still a lot of, like, misunderstanding about why people use drugs, how they use drugs, even the fact that, people share drugs with their loved ones, right? So there definitely needs to be more education on those fronts. And, I will say that the criminal penalties that are being imposed, unfortunately, are hitting people at the lowest levels of the drug distribution chain, and they're overwhelmingly Black and brown. Immense racial disparities that we're seeing in federal sentencing for synthetics. So I'm talking about fentanyl analogs specifically. But yeah, no, I really appreciate that question. I think you can't talk about this topic without bringing in the racial disparities that we're seeing.
Louise, I'm wondering if you could kind of expand on what the experience has been through the National Survivors Union and its advocacy that has been engaged around, specifically around these intersections of the drug war in the era of synthetics with structural racism.
This is so important, and I was just writing it. Uh, Drug user cultural competency. Like, we need some cultural competency around this. Like, people have no idea what they're talking about when they're talking about drug users, you know. y- and we know that the people that are getting harmed are not, like, even though I don't necessarily agree with any of it, the high level cartel dealers are not the ones getting the charges that they said that they said we're going to receive the charges from these, from all of this intense criminalization. It's friends, it's family, it's the people selling the drugs, the people that are the middlemen. It is a kindness to give someone drugs, and we see it throughout our society. We just have it pictured differently in our head because of the way movies operate and the way we show people things on TV. Ooh, there's the evil drug seller, and he's selling to the nursery. People don't want to sell you drugs or give you drugs if you don't want them. That's just the way it is, for the most part. And people who use drugs sell drugs, and people who sell drugs use drugs. And the problem that I see in all of this is there's always somebody to send down the river. We're going to let these folks, take all the pain because we don't want it. We don't want to. So it creates these hierarchies within the community as well, which is damaging and dangerous, and destabilizes the market, and destabilizes and really affects how people treat one another, and they do it on purpose, creating distrust within the community, using snitches, and all of the things that criminalization does to create destabilization, and all of these little tricks, and the bottom line is everybody suffers, especially the people with the least, especially with the least amount of resource, especially who, I mean, it is devastating. And then once you have, people don't understand what a criminal record does to you. We say, oh, there's jobs for people with criminal records. We have banned the box. We have this. I'm not talking about jobs. I'm talking about careers. I'm talking about being satisfied in your community and being listened to and being heard. And that's what the union is all about. It's all about becoming a community and part of something, and falling back in love with life, and not being separated and ostracized. And it's a shift that happens when you're sitting on a Yale panel, right? And somebody's finally listening to you again. You don't feel separated and lost or as lost as maybe you did the day before. Maybe there's a kindness and an approach to that. Maybe part of including people that use drugs in this is not just the wonderful information that you get, but it's also about giving people, giving people access to jobs they're really good at or careers they're really good at, the things they know about. You know, everything changed in my life when I was not so separate. When I was not, we separate people from their friends, we separate people from their families, we separate people from their jobs, we separate people from higher education, and finally we separate them from their freedom. And when we separate them from their freedom, then we see death. Because, what do you have to live for? You've taken everything from a person. And that's the kind of thing we need to be talking about, is community building and not allowing these kinds of hierarchies and separations and racism and all of this to fill these policies and allow people to think they're doing something that they're not doing. If you think that your little son Nicky is buying drugs from some evil dealer, and no, your son Nicky is probably selling drugs too. Just like you would give somebody an Oxycontin or a Tylenol if they hurt themselves at your house, you're quick to hand them a wine or if we would think about drugs the way we think about alcohol, we would be so much, things would be so much clearer. And alcohol is a drug. It's just the way we've been trained, or the way the markets have taught us to talk about it, that changes, all of that stuff. But absolutely, I don't think you can talk about a drug war without talking about racism. I think it's all about racism, and racist policy. And, why else do we not have tools of engagement for people that smoke drugs? Why else do we not have tools of engagement? Like, why it's unacceptable. And the more we avoid it and the more we act like it's maybe it is the thing. It is the thing that we need to be talking about, and not allowing we can't allow people to shift the conversation. This shouldn't be a political issue. This is public health, period.
Yeah, no, thank you, Louise. And I mean, it really centers for me the extent to which I think it's important for us to always center how the drug war specifically is intended to be a mechanism of structural racism. Jaime, I'm thinking of your work along the border and the spaces you've moved between, and I'm wondering if you could kind of describe to us how you've seen in different ways structural racism, but also even citizenship status structure out vulnerability to engagement with synthetics in the drug supply over time.
Yeah, the southern border, right? Just joking, but I mean, it's because it's really, there's two. We also need to talk about what happens between the United States and Canada, right? Let's not forget this. We are all part of this North American system. It cannot just be look out into sometimes U.S. and Canada. When we want, we throw in Mexico in there, right? I think, unfortunately, what we see on the Mexican side is that people who use drugs, independently of their race, citizenship, are really the lowest on the value scale for the government, such in a way that we don't even count how many people died of overdoses in Mexico. And this is also helping to drive this narrative that if then we don't have overdose deaths, then it's not a problem. Now, let's not forget that, for example, Mexico has experienced in this last 5 years of this current federal government, around 30,000 people died from homicide. In Tijuana last year, around 2,100 people died of homicides. That's almost 8% of all homicides that happen in the country. So it's really not only something that we should measure on the amount of people that is excluded from, these overdose statistics, but also those that are actually included into those homicide statistics that we need to count. Just like Louise was saying, we need to broaden the scope into what we consider the cause of this drug war, right? Now, what we have seen is really interesting, because in the border is really where we understand that this phenomenon is not restricted to just one citizenship. into the organizations that we provide services to, we have American citizens who, because of different reasons, have to either migrate south because of cost of living. They may also have to move south because it might be easier to buy and use substances. Maybe they also went south because their partners were deported and they could not leave them behind, so they moved down to Mexico. So we can see that substance use really affects everybody, and we provide services to everybody. Now, I think that's something that is important for us to recognize, is that unless we go to the real cause of the situation, which is the lack of support and availability of, for example, safe supply for people all throughout North America, we'll be just kind of like a whack-a-mole game, right? Where we like say, all right, now we make it harder to acquire fentanyl. So, for example, right now, the Mexican president has put on a constitutional reform to make it unconstitutional to produce, commercialize, and transport and consume fentanyl, like if no one had thought about it ever before, right? So he even came out and joked that Mexican scientists are gonna invent the new substitution for fentanyl. So we really are going into these illogical ways of trying to say, if we prohibit it, people will stop using substances, and that's completely out of every possibility. So we really need to put the point into what we actually need. We actually need to put those substances who are not really into high toxicity levels into the ways of hand that can then use them in a way that might be safer for them, right? I mean, for example, Mexico didn't have methadone for 17 months in the country. So obviously people had to relapse and go back to a market that is tainted with fentanyl and other things. So if we don't put those options, whether to people who wants to get into treatment or the others who are not really ready to get into treatment but want to continue using substances in a safer way, then we're really never gonna go and really tackle to the real thing about what is at the beginning of all causes. And I would just like to also mention one thing that you said before, Ryan, which is, no, fentanyl is not in everything. And this is something else that we need to be really, really clear, right? It is not, we haven't found it really prevalent into methamphetamine. We never found it in psychedelics, in spite of evidence of some scientists saying in Mexico City that it was an MDMA. We have never seen that anywhere else in the world. And that's really important for us to put out there, because if we don't say the real things of where we can find fentanyl, then we're never going to be tackling the real issue, which is in the legal office, where we need to have those safer and the safe supply options for people who really need it.
Yeah, no, thank you. I mean, I appreciate you bringing that up, because I'm always thinking opioids when I'm talking about fentanyl and how prevalent it is in the supply. So I appreciate your attention to, no, it really isn't in everything, and we do need to be specific in our language. Kind of building off some things that we've been talking about, but kind of changing gears slightly. Maritza, certainly as we've seen these ongoing shifts, there's been so much more policy attention to this issue of synthetics. And as you've kind of talked about a little bit already, these very much uphold drug war logics. They're structured around banning precursor chemicals, enforcing greater sentencing disparities for people. And I'm wondering if you could kind of briefly kind of characterize where you feel scheduling is currently in relation to synthetics. And here I'm very interested in what you feel it might misunderstand about what's happening right now.
Yeah, thank you so much for this question. I'm really eager to talk about this actually, because there are a couple of things that I want the audience to know, because they're really relevant to what's happening in Congress this year. So first, I'll say that what we're seeing at the congressional level is, again, a knee-jerk reaction to overdose, where Congress is for the first time learning about substances like xylazine, and their knee-jerk response is, oh my, we have to put it on the drug schedule. It's not on the drug schedule, must get it on the drug schedule. And for folks who aren't familiar, when things are scheduled at the federal level or placed on the Controlled Substances Act, criminal penalties attach. So that means harsh mandatory minimums a lot of the time. It means long prison sentences, and it means all of those horrible collateral consequences that Louise was talking about earlier. So, earlier I said that, on one hand, I do appreciate that there's been more of an acknowledgement that we need a public health response, both from the administration and Congress. That's true, but we have also seen that they continue to want to lock people up for drug activity, and they're not understanding how criminal-based approaches harm people who use drugs and harm actually all the efforts that they're putting toward the public health side of things. And again, there are two specific examples that I think really illustrate this. One is around how Congress is currently treating fentanyl-related substances. So since 2008, Congress has extended a Trump-era policy known as class-wide scheduling of fentanyl-related substances. This policy automatically places all fentanyl-related substances on Schedule 1 of the CSA. And again, this means harsh mandatory minimums for substances that are untested. So this is a class-wide approach to scheduling substances. That means there's no testing. Normally to put something on the CSA, there has to be a medical and scientific review. In this instance, Congress is saying, oh, it's related to fentanyl, must be bad. Let's apply the harshest criminal penalties. And the reason this is bad is because what we've learned over the years since this policy has been in place is that not all of these substances behave the same in the human body. Some are harmful, but some have no effect. Some are inert. And actually, they've actually found substances that behave like naloxone. In other words, can reverse the effects of an opioid overdose. Yet Congress is treating them all as equally bad without any testing. And this also imposes barriers to research because when things are placed on the CSA, you have to, the DEA restricts what you can study, and you have to go through all these, hoops to even study these substances. Think about that. At a time when we're facing massive overdoses for fentanyl, we're restricting what scientists can study, what researchers can study, including things that could potentially act like naloxone. It's really alarming. And the reason I bring this up is because it relates to everything we've been talking about today. We're also seeing racial disparities in fentanyl analog prosecutions generally. One thing we've been telling Congress is we don't need to criminalize fentanyl-related substances because we can already go after these cases. If that's the goal, right? And it is the goal, is what they say. There's already laws on the books that criminalize that activity. So it's not necessary from that perspective. But also the data tells us that it's Black and brown people who are being prosecuted for fentanyl analog prosecutions, generally, overwhelmingly. And we're talking about people, again, on the lowest levels of the drug distribution chains. So, people who sell drugs, probably, again, because they're also people who use drugs. Related to that, we're seeing the same approach with xylazine. And by the way, this fentanyl policy that I brought up, it's been extended on a temporary basis several times since 2018. But the reason I wanted to bring it up today is because this is a big year for this policy again, because the policy is set to expire last day of this year. And every year when this policy is about to expire, there's a big fight. And, we go in telling them this policy needs to expire. This is not what we need. By the way, here are all these public health centered bills that you can pass instead. But this is going to be a particularly tough year because it's an election year. On top of that, unfortunately, Joe Biden has already supported this class-wide scheduling approach. So that is certainly not helpful to our efforts. But we're seeing a similar thing on xylazine. Louise said earlier that they've known about xylazine and have been talking about xylazine for years. A lot of people have, but Congress just discovered it I think maybe last year. And of course, their knee-jerk reaction was let's put it on the drug schedule. Let's make sure that, we save lives by criminalizing it. So unfortunately, now there's an attempt to place xylazine on Schedule 3 of the CSA, which again means criminal penalties, even for things like possession. And similar to the fentanyl law, what we're seeing with xylazine is that one, the research tells us that it doesn't belong on Schedule 3. Scientists who have already dug into xylazine tell us that, chemically, it actually behaves like something that shouldn't be on the schedule. There really isn't precedent for something like this on the CSA, especially not on Schedule 3, not that high. So that there's that. But we also know that, again, if you put something on the CSA, it's harder to study. This is a moment where we need all boots on the ground in terms of understanding xylazine, how it's showing up in the supply, what it does to the human body. But instead, Congress wants to place it on the CSA, which brings all these research restrictions. And then, of course, I already talked about criminal penalties. Similar to fentanyl, xylazine is used with fentanyl most of the time and fentanyl analogs. Again, already laws on the books to prosecute these cases. There's no need to make extra criminal penalties for this. And like with fentanyl, I really fear that we're going to see this, if this goes through, that it's going to disproportionately fall on people who use drugs, people who are who are at the lowest levels of the drug distribution chain. And we know that scheduling won't prevent overdose deaths and actually makes the drug supply more dangerous. And, I think a common thread with both fentanyl and xylazine that we're seeing at the federal level is sort of what I talked about earlier, that there really is a fundamental misunderstanding about how criminalization harms people who use drugs and makes drugs riskier to use. There's also misunderstanding about who uses drugs and how people use drugs, that people both sell and use, and often with their loved ones. And like I said earlier, I do think some of this is intentional. I do think some of it is lack of education around this issue. Also, it's like easier to score political points, to throw certain people under the bus, right? That's like has always historically been true, and that hasn't changed, especially in an election year. Again, I go back to that because we've really started to see a backlash late last year, and I think we've really been feeling that a lot this year politically. But yeah, I think I'll leave it there. Anything else I would say, I think might be repetitive, but that's essentially what we're seeing, and it's only getting worse this year, unfortunately.
Yeah, no, great. Thank you. And I mean, you touched on something I mean, it consumes me right now, and that's how do we grapple with this backlash that we're seeing against harm reduction, against, I mean, honestly, justice and even humane ways of approaching substance use, given constant media coverage of conflating substance use with rising homelessness, because it's not a housing crisis by any stretch of the imagination. And I'm wondering, and I would put this to everybody on the panel, including America, because I'm curious as to how this plays out in European context as well, is what do you feel is needed to kind of bridge the gap between what's actually happening with the shift to synthetics and kind of bringing the public along or policymakers along to better understand what's happening, and that we can't continue with the approaches we've had historically, because they're essentially what's driving this incredible amount of harm that we're seeing.
Again, in the European Union, we have the so-called balanced approach. So it is considered that drugs-related issues have to be responded with health and security in a balanced way, where public health has an important role. And as in any aspects of public health, drugs-related issues are not distributed equally in the population, but exactly as any other issue. So of course, we need to support more and to protect the ones that have less access to services, less capacity for defending themselves, for choosing their life. There are interesting interventions on housing, for example, because it is recognized that, and it was made very, very clear during the pandemics, that people without a stable habitation were more susceptible to infections, didn't have access to the technology through which we communicated to each other. So in some countries, there were special interventions even to provide devices to people to access telemedicine, for example. So I think this is a very important approach that we need to foster. The pandemics also taught us that health is one. So you don't have a group that can be ignored, because we are all in the same environment. And if someone gets sick, this is spread to all the population. So you need to be altruistic, even for egoistic reasons, if I can use this oxymoron. And I think this is very clear in our declarations. But I agree with what was said before, that we need to take care of the local decision makers. Europe has a very rich diversity of languages, histories, traditions, everything. So it is very important to us, first of all, to foster sharing of experiences, because as Jaime was saying before, substances can go through the countries, so someone that experienced first can learn important lessons for others that will only be affected later. And this is very important to us, and is an additional effort because frontline workers sometimes don't access the English language. So we need to make sure they are able to communicate and to exchange their experience. It is of extreme importance to have sentinel systems that are able really to reach those who use drugs, because they experience and they know something before we reach through databases and research. So it's of extreme importance. There are some very nice experience, for example, of geolocalization of overdoses, like frontline, in this case, medical doctors dealing with an overdose put their data in immediately, shared their data with others in a way, because substances can also move from one local situation to the other. So if you have an overdose, you can quickly inform the surroundings to be prepared in case. So I think we have a very rich level of experience beyond the evidence, the scientific evidence, also very interesting experience. And it is our role to make sure we capture this experience and we make them available for everybody. I have a lot of hope. I put a lot of hope on the new technology to speed up these processes, to be very quick in sharing these experiences and engaging with all the interested stakeholders.
Ryan, if I can jump really quick, which, I admire always from the European, the fact that they were able to kind of like put on harm reduction into a bubble of leaving it outside of the politics. And just like Marisa was saying, it seems like on these times in politics, harm reduction, and let me use my Mexicanness here, has become the piñata for every candidate, right? Let's distinguish first that there might be some people who says that they support harm reduction, but if you do not put money into it, those are empty words. The Mexican government has on its mandate that they do harm reduction. However, they defunded every single harm reduction program, and we have no public available syringe exchange programs in Mexico since 2018. But still, you put it into a government thing. I got to recognize that at least in the United States government, through the White House putting as an official arm harm reduction, because obviously of this overdose crisis, money has gone down to communities. It's unfortunate that it has gone down because of this situation, but at least there is money to be used in the local level that now harm reduction organizations are able to put into action on the ground. However, I believe that unfortunately, we are seeing what is a witch hunt to try to blame harm reduction for an increase or not a decrease of overdoses, as people will like legitimately, they say that if we are doing these actions, we will expect overdoses to go down. But as we have seen from our European partners, this takes a generation. This action takes decades to create all these systems around so we can really tackle the issue. And unfortunately, our politicians are just focused on 2 years, 3 years outcomes. And that's not only in the US, we can see it clearly now in Canada as well. Well, while in British Columbia is a bubble of harm reduction, we see other provinces who are defunding harm reduction. And we're seeing is an increase in overdoses. So we really need to be aware of that one, we need to put money next to harm reduction if we really want to make an impact. And two, we need to take it out from that political arena and just embrace it as a public health action that is going to take some time for it to work. But we all need to agree that it's one part of all the strategies. And it's not against treatment. We, as harm reductions, believe we are also hand in hand with treatment, but we need to have everyone push in the same way, because otherwise we're just going to fight each other, and unfortunately, lives are going to keep, getting lost into our communities.
Yeah, thank you, Marika. I see your hand up.
Yeah, because I listening to you, I thought something that is becoming important to me, and I'd like to hear your ideas about it, is that we should also overcome this separateness among prevention, treatment, harm reduction, and social reintegrations. Because real people move from one situation to the other. So the idea of saying, okay, this is prevention because you have never tested drugs. This is harm reduction because for you there is nothing more we can do now. It's terrible. Is against the idea of people that are in continuous dynamics. So we cannot accept any longer someone saying, okay, we support prevention, but we don't like harm reduction, because it's the same global way of taking care of these problems. And I think this is a dialogue we should, again, develop, giving time to people to understanding, but it's really what we should do. As you said, pushing all together to make it clear that harm reduction is a safety network to make sure that people is free to choice. So if someone is only in favor of treatment, should know that harm reduction is very important, is an ally of treatment, and that we need to support the people choices. What is very bad is when someone has no choice, and then people without choice can become dangerous for the community. It's true. So I really think there is a big cultural work that we can do all together to make sure we are looking in the same direction, because my experience, and this is really my personal experience, is that sometimes positions that look very different, when we start agreeing on the outcomes, then become closer. We all agree that we don't want to collect bodies of people dead in the street. We do. So then backward, agreeing on this point together, backward we can see what are the options that we have to reduce this tragedy. And I have hope that we can work in this way.
Great, thank you. I'm getting conscious of time, and certainly one thing I would be curious, given folks are kind of positioned in occupy space everywhere. I'm wondering what people feel is kind of the emerging issues in relation to the drug supply and synthetics right now. If we're looking forward, I think if we look back 5-10 years, very few of us would have anticipated going through the series of shocks and changes that we've since experienced. And I'm wondering, if we look forward, what might be the things based on current signaling that we need to start thinking about so as to be positioned to better respond.
I mean, I can jump, really quick, and I think Luis touched about this, is the stigmatization of inhalation. These jump into synthetics has given the choice that people now can also smoke their drugs while they were reluctant to them before. And here we are kind of like discussing 20 years ago whether needle exchange was something that we should do. And now we're throwing like the same way the pipes discussion. We should encourage people to smoke. And again, this is something that the Europeans, for example, the Dutch did 30 years ago into their safe consumption services. We're talking about safe consumption services, for example, in Canada, but how many of those are inhalation sites, right? And the one that we have in the unsanctioned, one of the other unsanctioned sites that we have in Mexico, we incorporated that inhalation possibility because we recognize that people have changes due to this transition to synthetics. So if we don't really start talking about those issues without stigma, but more like what Marisa was talking about, like how we criminalize these substances, then we are missing those opportunities to make a real health impact in a positive way.
If I could just say this, I am really exhausted with hearing, we're going to have an anti-stigma campaign. We're going to do this. How can you even talk about ending stigma while you have criminalization? The purpose of criminalization, unless I'm confused, which I may be, is to stigmatize so that people won't behave in a certain way. When we've got one arm of public health pouring money this way, and then we've got money pouring this way, it would seem to me that we are we are undoing what we've got a good thing going on over here, and then we undo it. The other thing we're doing, but I'm just going to say it outright, is we've learned how to incorporate people that use drugs with advisory boards and these things. They don't work if you don't educate the people on the advisory board. Just being a drug user is not the solution. We've got 20 plus years of abuse. We've been abused. We've been mistreated. We've been told this is all our fault. We've been told that this is individual level, that I was selfish and self-centered and I did this. And this is structural, this is cultural, this is societal. Like, we need to teach people about the social determinants of health. We have a program, sorry, we have a narco-feminism program that's all about this. It's all about the re-education and repositioning of these tropes that are killing us. I wake up every day like, I'm a piece of shit. I did this to myself. I destroyed my family. This is what we've been taught. The infant, I can never say the word. The infant, say it for me. In
It's
treating people like children, of people that use drugs. I hear people talking about, these are my kids in these groups. No, we're adults. We're grown ass adults. We're grown ass adults that have been mistreated. We are people that need to come to the table as adults. You can't let us sit there for 8 hours after we have been on the streets and doing the things we do. I mean, oh, you can't have them early in the morning. Well, maybe we don't work early in the morning. I simply don't start my day until 12 because I'm out until the evening, and I'm doing things in the evening where there's people that I need to serve that are out at that time. I mean, we want to work with drug users until they act like drug users, until it infringes upon our precious 9 to 5, or until it upsets us, until we have to talk a different way, until we have to unpack, like, why are we talking so fancy about something that's just simply, there's just an easy way to describe it. It doesn't have to be described in these terms to gatekeep and keep us out. If we want to work with drug users, there's a way forward. There's a way forward. You pay people, you treat them with respect, dignity, you listen to them, you make sure you got diverse folks, you make sure you don't have one person, because we'll exploit the rest of the people because, there's not enough. We're scared we're not going to get ours. We need to be educating and treating folks with respect and bringing them in and doubling down on really the way we do this work. Research is too fucking slow. Sorry. By the time you guys are cycling around about this, we're already dead. We've got to start listening. There's got to be a faster way to get NIH proposals. There's got to be a faster way to talk about xylazine. There's got to be a faster way to get boots on the ground and get information. And we don't disseminate the results either. So we got paywalls. We want to work with drug users, and then we have a paywall so the drug user can't read the result of the study. We can't even get in to read it. We need ways of doing things that make sense instead of all the gatekeeping. Let's open these gates. Let's get this stuff Roland, let's work as a team. People are dying. This is not okay. Are we so individualized? Do we have to wait till everybody's so uncomfortable to do something? I mean, we certainly don't care about people that use drugs. I mean, that doesn't seem to be getting it. Even though people that use drugs are our families, are the people that we love. Everybody, is affected by this thing, and we've got to put our brightest and our strongest. And I'm going to say this: we also need to be thinking about solutions while we're fighting, because what happens is we have something open up, and there's a time to maybe put something there, and we're not ready because we've been so busy fighting all of the negativity that we don't have the answer, or we don't have a good answer, or something that'll be thoughtful and that has considered the unintended consequences, that is really got all the brightest and the smartest people at the table. We know that that's what you've got to do. This doesn't work, but let's go ahead and let's go ahead and reimagine something that will, because we're we're not ready when we have opportunity, and we need to be ready when there's opportunity. We need to have solutions ready to roll, ready to go, because we've got families destroyed and trauma. We got a lot of work to do to undo any of this mess.
Great. Thank you, Louise. I think you've captured so much of the work that we need to do. I think we're a few minutes from closing, and so I'd love to put a final question to each of you in really no more than a minute, and that would be, you know, what most critically do you feel needs to happen immediately and that we can work toward to address synthetics and better enable us to have a response to the overdose crisis that works? And I'm going to go clockwise for me, or starting with Maritza.
Yeah, thank you. So immediately what comes to mind is exactly what Louise said around stigma, that we really need to destigmatize people who use drugs. We need to talk about it not as a moral failing, but again, as a health issue. So that definitely means ending criminal penalties, but it also means scaling up harm reduction services. I think everybody today touched on the fact that even harm reduction services are certainly nowhere near where they need to be. But I also just want to talk about overdose prevention centers and like really embracing overdose prevention centers. Like there are proven things that we know save lives that we're still pretending like, don't work here for some reason. So I'm hoping we can see some really, I hope that we can see some more states open up overdose prevention centers. I'm hoping we can build federal support for overdose prevention centers. That's what my team's trying to do. And I promise you we'll continue to push on that. And then I want to talk about safe supply. Unfortunately, that's not something that we're doing now, but like that's where we need to be. That's definitely where we need to be, because we know that that will certainly save lives. It will, it will give people the substances they need to live their lives, but not deal with the harms of drug use, right? So I want to see a world with safe supply, and hopefully we can get there one day.
Thank you. Jaime.
Yeah, I think we need to start thinking outside the box. And yeah, while we talk about safe supply, we need to consider to both medicalized options, but also non-medicalized. And in that way, I do want to give a shout out to my friends and colleagues from the Drug User Liberation Front, DOLF, into showing that another way to delivering substances that are not tainted is possible. And despite that the government decided to go against them, they show that they save lives. So this should serve as an example that we should just do in the spirit of harm reduction first, and then wait for the sanctionality later, just like we do in many of the unsanctioned sites that we have in Mexico, because just like Luis said, people are dying.
Great. Thank you, Marika.
I think to work and to study around drugs-related issues requires a lot of honesty with ourselves. It is difficult, it's not easy. And I think we need to use this honesty also to understand resistance that can be on the side of decision makers. Once we demystify the concept, we take the ideology out of the scene, and we talk about outcomes, then we probably can start talking together in a way. I adored what Louisa said before. We need to be prompt. The world is not waiting for our scientific results to be perfect and to be published. And we need to learn. I would like to say democracy is a package. It's not just the right to vote. You need also to keep people healthy enough to understand, to study, to be curious, to experiment new things. It's a package. We need to apply the public health approach to keep people healthy enough to develop their potential. This is what I think is the difference between infantilizing and respecting, is to understand that each of us develop their own potentials, not the potential that someone else has decided we have to implement. So from a European point of view, I would say I feel privileged. We have a lot of tools and experience and synergies to work together. The world is running faster than a few years ago. This is a matter of fact. So we need to run at the same pace, if not faster. And I think we need to use all the available technology. The technology allows also better ways of working together, sharing ideas, reaching consensus conclusions. So we really need to put all our energy to be effective.
Great, thank you. And finally, Louise.
Thank you so much for that thoughtful response and all of these responses. I really have very little. I mean, I've said so much already. I just know we can do better. I know that we need to watch these synthetics. What we are finding in the drug supply really is alarming, and people are affected. It changes people's behavior when they what's in there, when they hear, when they understand, it changes people. So safe supply is so important. Drug checking is so important. Overdose prevention sites. We need to remember, and I say this all the time, but you have to die to receive naloxone. We need to be upstream a little bit. You know, naloxone's wonderful, and it saves so many lives. But we've got to do better. We can't just be satisfied with bringing people back to life after someone's been naloxoned, 10 times. They're not the same people. This affects your brain. This affects, we don't even know. We don't even know the consequences of that yet. So there's just so much work to do. We need to partner with people that use drugs. Thank you to all the drug using people that I work with and all the people that work with National Survivors Union, North Carolina Survivors Union, and all of the survivors unions. And thank you to our allies out in the world.
Great, thank you. And I'd like to thank you all for such a wonderful discussion. I learned a lot, and it was great to connect with all of you. And thank you everyone who joined us for this first in our series of webinars focusing on the shift to synthetics. The next webinar will be on April 16th, and information should be going about it soon. So I hope you can find time to join us, and that everyone has a wonderful rest of their day. Thank you so much.